All right, everyone, welcome. We're going to dive into something that's absolutely critical to what we do here at Hospital in Makati, adult fall prevention and management. Now, this isn't just another protocol to memorize. This is about our core commitment to keeping our patients safe. So let's jump right in.
Here at OSMAC, patient safety isn't just a buzzword. It's everything. And we all know a single fall, man, it can have just devastating consequences for a patient and their family. This whole protocol, think of it as our game plan, our roadmap to making sure we're doing everything we possibly can to prevent that from happening.
Okay, so first things first, let's make sure we're all on the same page. What exactly do we mean by a fall event? The official definition is a sudden, unintended, uncontrolled, downward displacement of a patient's body to the ground. The big words to focus on there, unintended and uncontrolled. That's the key. This is the baseline we're all working from.
All right, Section 1, Assessing Adult Fall Risk. This is the first step, and honestly, it's probably the most important one. So, what's our go-to tool for this? For any inpatient who's 19 or older, we use the Modified Morse Fall Risk Assessment tool. The reason we stick to this one tool is simple. It ensures that we're all speaking the same language, whether you're on the day shift, night shift, or in a completely different unit.
Let's take a closer look at what this tool actually measures. There are 6 key things we look at. First, and this is a big one, history of fall. Has the patient fallen recently? That alone is worth up to 25 points because, as we know, it's the best predictor of a future fall. Next, a secondary diagnosis. Does the patient have more than one thing going on? That's 15 points. Then, ambulatory aid. Are they using a walker, or are they kind of grabbing onto furniture to get around? That can go up to 30 points. You also have to consider patient care equipment. IV poles, catheters, all those things that can become tripping hazards. That's another 20 points. And finally, we look at their gait. Is it weak or unsteady? And their mental status. Do they maybe overestimate what they can safely do? Each of these gives us a crucial piece of the puzzle. So you add up all the points. What do the numbers mean? It's pretty straightforward. If you get a score of 0 to 24, that patient is considered low risk. Now, if the score lands between 25 and 44, okay, now we're in moderate risk territory. This is where we start to add extra layers of protection. And then anything 45 or higher, that's a red flag. That patient is officially high risk, and that triggers our highest level of intervention.
Now, this is super important. The assessment is not a one-and-done thing. You can't just do it on admission and forget about it. A patient's condition can change in an instant, right? So we have to keep reassessing. When? Well, of course, upon admission. But then it's daily for our low-risk patients. And for moderate to high risk, it's every single shift. Plus, anytime there's a significant change, they get transferred, they have a procedure, or after they've had a fall, you guessed it, we do a full reassessment.
Okay, next section, from score to action. Because a number on a chart doesn't help anyone unless we do something with it. Let's talk about implementing interventions.
Okay, let's start with the basics. These are the universal fall precautions. And universal means every single patient, no exceptions, regardless of their score. This is our standard of care. We're talking about the simple but crucial stuff, making sure the call light is always within reach, keeping the bed in a low position with the brakes locked, the floors clear and dry, and making sure the patient has non-slip footwear. These are the non-negotiables.
So what happens when a patient scores higher? We start adding layers. For a moderate risk patient, we do all the universal stuff, of course, but we also add visual cues, a fall risk ID band on their right arm, and a sign on their bed or door. Now, for our high-risk patients, they get all of that, and the process escalates. The physician has to step in for a full-on, comprehensive evaluation of their physical and mental state, which might mean calling in specialists. It's all about matching the level of intervention to the level of risk. All right, let's shift gears. When a fall occurs, your immediate response. Because even with the best prevention, falls can still happen. What we do next is critical. Okay, you're the first person on the scene. What do? Here are your first 5 actions. 1, get to the patient, make sure they're safe, and try to make them comfortable. 2, run through your ABCs, airway, breathing, circulation. Basic life support, right? 3, assess for injury. Is there anything? Is it minor, major, or are they okay? 4, notify the attending physician immediately, no delay. And 5, document. Get everything down in the patient's chart. A clear, calm, step-by-step response is key here. Now, after the immediate response, there's one more crucial step.
Every single fall event has to be reported using the patient safety event reporting form, and you've got to get it done within 24 hours. And listen, this is so important. This isn't about pointing fingers or getting anyone in trouble. It's about learning. It's how we spot trends and fix bigger problems so we can get better as a whole hospital.
Okay, last section here. A shared responsibility. It takes a team. Because this isn't just a nursing issue or a doctor issue. It's an everyone issue.
So who's responsible for patient safety? Well, look around. The nursing staff. You're on the front lines doing the screening and the patient education. Our medical staff. You're providing those timely evaluations post-fall. Our clinical pharmacists are looking at meds that could increase risk. Even general services plays a huge part by managing the environment. But really, who's responsible? The answer is you. Every single one of us is a vital part of this.
So, as we finish up, I just want to leave you with one thought, one question to carry with you. We've gone over the tools, the scores, the protocols, but at the end of the day, it all comes down to personal commitment. So the question is, how will you make patient safety your first priority today?